Greetings, everybody. It's a pleasure to be here today and see all of you for the 26th of our series of town halls. I can't believe, again, it's already 26 of these. And as we've done this whole year, really the major focus now is on many of the excellent things happening across our institution. Today, specifically, how to be safe this summer as we enter hopefully a great period of the season for us in Houston and with all our travels and everything else. I want to always thank our Society for Leading Medicine, Jeremy and Caroline Finkelstein, Catherine and George Masterson for their chairing of that great organization, and thank each of you for your tremendous support. We're going to actually go a little bit long today because the theme was already pre-planned and we've got some great speakers, but with enough COVID coming back, we're bringing back by popular demand Dr. Dirk Sussman, and we do want to talk briefly about monkeypox as well, since that's kind of a hot topic out there, and give you all a little bit of the information about that. Because we've got three very diverse and broad topics, we do not have somebody in the background doing some of the texting and things, but you can text us and we will do our best to answer all the questions at the end. So if you are interested in that, text the word DeBakey, D-E-B-A-K-E-Y, to 37607, and we'll get to all of the answers that we can possibly get to. So, as I said, our theme is keeping safe this summer. We have three great guests today. We have dermatologist Dr. Farah Shah, who is President and Chief Executive Officer of Houston Dermatology Associates. We have Dr. David Huston, who's the Director of the Houston Methodist Immunology Center, and we have Dr. Neil Gandhi, who is the Medical Director at our Houston Methodist Clear Lake Emergency Department, as well as one of our regional emergency medicine directors, and each of them will talk to you about various aspects of staying safe. I'm going to start with Dr. Shah here to my right.
Pleasure. Thank you for being here. Thank you. Let's go ahead and get started. So when we talk about how to be summer sun smart, what I usually like to do is start off with a little bit of education. You know, why do we have to be smart in the sun? Isn't the sun good for us? So let's just get started on that. What is all the fuss about? Well, we do know that the sun emits ultraviolet radiation. So with that, we know that there are different rays that are coming through. Why is that important? Well, the ultraviolet rays have been now labeled as one of the top carcinogens among human beings. Okay, so now we've got this carcinogen that is one of the top carcinogens among humans, and it's out there. Why is that important? All right, let's move forward here. Let me just go back to this slide real quick. So coming from these rays, we've got three kinds of rays that come through to the earth. The strongest ray that does not get filtered by the ozone layer, and I like to do a little bit of education first, because I think as we learn about and we try to understand why it's so important that we do protect ourselves, because we all know what happens in the sun and skin cancers and all that, but I think getting a good idea of sun and why and how it damages us really gives us an idea of why we need to protect ourselves. And that education, in my opinion, has always been pretty important to moving forward in educating our children, our teens, etc. So back to the ultraviolet radiations. Three rays are coming through to the earth. The UVC, which are the weakest ones, get completely filtered through our ozone layer. So those aren't coming through. We've got the UVB and the UVA. The UVB, we know, are the ones that come through in a smaller quantity, and those are the ones that are going to cause the burn. The UVA is now 95% of what's coming through the ozone layer into the earth. It's not filtered by the ozone, it comes through the clouds, it's not filtered through glass. So those are the ones that we're going to talk about, let's skip this slide real quick. Okay. So looking at this slide, we've got the UVB, which is about 5% of what's coming through, the UVA about 8%. Well, this is really, really interesting because the UVB basically just penetrates the superficial layer of the skin. Okay, so what does that do? Basically, that gives you a sunburn. Okay, it does damage your skin, but it's basically a sunburn. Does give you skin cancers, but basically more of a sunburn. You feel it, you start to burn, you come out of the sun. What about the UVA rays, which is, like we said, about 95% of what's coming through and is not filtered? That's going to penetrate deeper. That's going to go way into the dermis. And what's going to happen? That's going to give you your genetic damage. That, not blocked by the ozone, penetrates glass, and that's going to go deeper. That's going to give you your premature aging and more of your DNA damage. And what's interesting, guys, this is ever present. This does not change, whether it's what season it is, daylight hours. As long as there's daylight, there's daylight hours, it's coming through. So there's not like the UVB where we usually will say between 10 and 4. No, UVA, it's always there, penetrating deeper. So we'll go back. Is this one, I think? Yeah. So what happens when these rays are penetrating? Well, as you can see, they're altering the DNA. Okay. So hence one of the most dangerous carcinogens, cancer-causing agents in humans. It's altering the DNA, and the skin is continuously trying to repair that. So looking at this now, we have an idea of what is going on. We've got these cancer-causing rays. We've got the UVB ones that are burning our skin. We've got the UVA that's going a whole lot deeper. So what do we do? Okay, so why is this so dangerous? Skin cancers are now the most common cancer in the United States. 1 in 5 Americans, and if you're Caucasian, you have a 1 in 3 chance of developing skin cancer. Melanomas, which are our fatal skin cancers, is the second most common cancer under the age of 30. And we've got 1 person dying every hour of melanoma. And that incidence is rising, okay? Why is the sun important here? And sunburns? 1 blistering sunburn will double your chance of a melanoma. Okay, so we know that. What else does it do? Suppresses your immune system. People don't realize that. A lot of people will say, for example, when I'm out in the sun, I'll get maybe cold sores on my lips. Why am I getting cold sores when I'm skiing and I'm out in the sun? Your immune system goes down. Very, very important. Another thing that people don't realize is the damage to your eyes. Cataracts, macular degeneration, ocular melanomas, which is also on the rise. This is something that we don't think about, but is also caused by the ultraviolet rays. Okay, so now we know, okay, so it's summer, I really want to go out and enjoy my time in the summer. And we all know you feel good when you go out in the sun. You've got your increase, dopamine, serotonin, all that, whatever. It's good. You feel good. So does that mean I don't go out in the sun? I mean, come on. So what I usually tell people is, no, you go out, but you're smart. You enjoy the sun, but you're smart. What do? We slip on sunscreen. We slip on a shirt, I'm sorry. We slop on sunscreen. We slap on a hat. We seek shade, and we slide on some sunglasses. So I'm going to talk a little bit about all of these, and then let's talk a little bit about the sunscreen. So this is something that has been under a lot of 4 or 5 years prior, the SPF rating that you see on the bottles, that SPF rating, believe it or not, is a measure of your UVB protection, okay? So you can come and tell me, well, I had an SPF of 1,000,000. All that's telling me is how much you're protecting yourself from UVB. We just talked about how UVB is just the burn. It's only 5% of what's coming through. It's the UVA. So there has been no rating system for UVA, which has been really, really a big issue because people have been misled to think that they can use a higher SPF and be protected. So a few years back, our academy kind of went to work and tried to get the labeling changed so that it would more appropriately be able to educate people of what really they were putting on and how much protection they were actually getting. So now the labeling, it still has an SPF number, but if it gives you the UVA protection, it will say broad spectrum. And there's actually an FDA, a class action lawsuit, because they were putting that label on the sunscreen bottles when there was no UVA protection. But that has all changed in the last few years. So now what you need to look for is an SPF of 30 or more. That means you've got your UVB protection. But you need to make sure the labeling says broad spectrum. Okay, so that's important. The other thing is all of our labeling and all the studies we've done are really only showing the SPF holding its protection up to 80 minutes. So really what we recommend is after about 2 hours, maybe even more frequent if you're swimming and sweating, you need to reapply. I know that's a hassle, and I hope my children are listening to this because they don't listen and they don't do that. But that really, at the end of the day, if you're going to consider all of these things and all of the data, that's what you need to be doing. There are also studies that show that we do not apply the correct amount to even hold that SPF. So when they do the studies and then what you're actually putting on is totally different. If you can see on the slide, it's about an ounce of what you need to put on your sun-exposed areas to get that protection, all your sun-exposed areas. So rule of thumb for me, just put more on than you think you need. Okay, don't make it a thin film and okay, I've got a little bit. Just put more on than you think you need. Other important things, even if it's cloudy, remember they penetrate the clouds. Something else is remember that you've got some that are water resistant, but even the water resistant ones are going to, after about 80 minutes, they're going to start to not hold their SPF number. So they need to be reapplied. All right. Okay. It's really, really important. Now that you guys know a little bit about SPF and how, it's really not, it's not really smart to just depend on an SPF because of all the things we just mentioned. So we really, really encourage people that, yeah, sunscreen is great, but really that should be second to protection. Okay, and protection in terms of clothing, hats, sunglasses, etc. So in terms of clothing, this is really, really a big deal now because there are a lot of the clothing industries with their ratings have really become a big deal. There's some really cute outfits you can get. And just sort of as a contrast, a white t-shirt. So if you wear a white t-shirt and you say, well, I'm going to keep my t-shirt on when I'm out in the sun, that's going to give you an SPF of about 4, if anything, which is nothing. So you are looking for a lot of these companies. There's Coolabar, there's a few more, and I'm happy to give you guys that information. But they have their own rating system, and it's called a UPF. It's an ultraviolet protection factor, and that tells you the protection from the fabric. And some of it actually have the UPF and the sun protection in the fabric itself, and some of it you get just from the weaving of the fabric. What we usually like to tell people is, unless you're wearing something like from one of these companies, Coolabar or one of these companies where you can see the UPF number on it, we usually recommend something that's loose fitting. We recommend a fabric that's tightly woven. For example, polyester, silk, those are really tightly woven fabrics. And we like them to be darker, not the light fabrics in color, darker, because they will absorb the rays and hence keep it away from the skin. So those are important things and easier. And now over the years, I'm realizing people are kind of doing that a lot more than relying on sunscreen, and really that's what we're recommending. Hats. A lot of my patients, wear baseball caps, and really you're not getting the protection you need. You're not protecting your ears. You're not protecting your neck. If you're going to wear something, it really needs to be a wide-brimmed hat with a brim about 3 or 4 inches. It avoids something that's got holes, like a straw hat or something. That's not helping at all. Again, a lot of these companies that have come out now, they have sun protective hats, really, really cute ones. They have a UPF number on some of them. So that's something that we recommend. More and more of my female patients are wearing the cute hats, and the guys too. They're kind of getting into it and doing that. Sunglasses. We are really seeing a lot with the eye damage, ocular melanomas, large eyeglasses with large lenses. That's what we want. A wraparound style to kind of protect all of that. And we'll talk in a minute about reflection from the ground, but that's what we recommend. And then really, really important, your lips. I cannot tell you how many people forget to protect their lips. And these guys, these patients, they come in and they have so much sun damage on their lips. And sadly, the squamous cell carcinomas that we see a lot of, when they are on the lips, they usually tend to be a little bit more aggressive, the oral part, oral squamous cells. So lip protection with an SPF, lipstick isn't going to cut it. And then lastly, tinting your windows. Remember, the ultraviolet rays are penetrating the windows of your car. If you have these long drives, long commutes, tint your windows. Couple more things. Reflection, sand, water, white painted surfaces, concrete, snow, those are going to reflect light. You're not going to realize it. You're going to get a lot of sun from that. Tanning beds, please do not go to tanning beds. Tanning beds are strictly UVA light. And when you've got a tanning bed, when you're going to a tanning bed, you're not getting UVB, so you're not getting a burn, so you don't realize. You stay in longer. You're like, I'm not getting burnt. That's UVB. It's all UVA. It's all penetrating deeper and going deeper and deeper. What do we do for kids? Kids, you don't need to apply anything for the first 6 months. Their skin is too sensitive. So they get shielded. You keep them in the shade. You wrap them up. At 6 months, you start your sunscreen. We usually like a mineral sunscreen, less likely to cause irritation. And guys, remember, the kids are learning the sun protective behavior from the parents. They're learning it from parents, teachers, coaches. Start modeling the behavior. Well, but what about vitamin D? That's what everybody tells me. I need vitamin D. But believe it or not, you're not going to get adequate vitamin D. The sun exposure does not give you an adequate vitamin D. You can get it from other diet and supplements, so you don't need to rely on a carcinogen. You're not going to get enough anyway from going out in the sun. So you might as well just rely on fishy oil, oily fishes, supplements, and sun smart. You guys, at the end of the day, put on a shirt, sunscreen, wear a hat, sunglasses, and stay in the shade. Thank you.
Staying in the shade. Well, thank you very much, Dr. Shah. I learned a lot. It's very, very helpful. And we'll get to some Q&A. I know there'll be some, I'm sure, coming in as well. Now we're going to move on to something else that can honestly spoil a vacation, spoil a summer, and that's seasonal allergies, which, of course, tend to kick in the spring, but then depending on what you're allergic to, continue on, as well as stinging insects, which can really make things pretty unpleasant as well. So we're going to now turn things over to Dr. David Huston. Dr. Huston holds the W. Bryan Trammell Jr. Family Presidential Distinguished Chair in Allergy and Immunology. You've been practicing that. I'm sure you can roll that off the tip of your tongue really quickly. So with that, I'm going to turn things over to Dr. Huston.
Okay. Thank you, Mark. It's a pleasure to be here with you today, and we'll get started. If I get... So this slide really reflects that there is a jungle out there that you have to navigate, and we're going to focus a little bit today on the some of the issues that come up, particularly in the summer months, but we'll address some of them that go year-round. And we'll also try to touch on some topics that you submitted as questions. So the statistics around allergic diseases indicate that well over half of the population in the U.S. has allergic sensitization to something, and many of those have multiple sensitivities. So it's a major health issue. If I can get this. Oh, okay. So very quickly, when people speak about allergies, they are generally talking about the immediate reactions that occur upon exposure to something they've been sensitized to. And as illustrated in this slide, the top pictures are electron micrographs of human mast cells. And these are the allergic cells that reside in the tissues throughout the body. And they get coated with the allergic antibodies, IgE, or the allergen antibodies. So they get coated by those, and the antibodies, I describe them as looking a little bit like lobsters. And so it's the tail that hooks on to these mast cells, and then the arms, the claws, have specificity for what they're going to recognize. And so it's that specificity, if they see it, they bind it, and that triggers those mast cells to degranulate, to release a whole treasure chest of chemicals that have different bioactivities. And on the right side is the electron micrograph of a mast cell that has been coated with IgE, seen the specific allergen, and causes it to release its chemicals. So that's our background mechanistic basis for what we're going to talk about for the rest of the time. So aeroallergens come in several flavors. They can be seasonal, and they can be perennial, year-round. Now this map illustrates several features about the seasonal aeroallergens by geographic region. And the geographic region is relevant because these allergens are derived from pollens. And the seasonal evolution over a calendar year is that in the spring is when you have your tree pollens. In the summer is when you have your grass pollens. And in the fall is where you generally have your weed pollens. And there are a few exceptions to that, such as the mountain cedars, the junipers, that will tend to have a winter burst of pollens. And these maps are changing continuously now with changes in weather patterns that are going on. And if you live in a region like Houston, you may be sensitized to tree pollens, grass pollens, and weed pollens. And for you, it's not seasonal, it's perennial. But the specificity of understanding what's driving your allergy symptoms is really dissected out by specific allergy testing, which can be done either with serum or preferably by skin testing, which has greater sensitivity and clinical specificity. So there are these seasonal allergens, and then we have the perennial allergens. And these are again, impacted by what latitude you live in, but what's up in the, in this upper panel, this is a herd of dust mites. And you're really not, if you're allergic to dust mites, they are here year round, but they are, it's not the dust mite animal itself that you're allergic to, it's their dung ball. And that seems to resonate a little more, gets people's attention a little bit more than saying dust mites. But obviously we're a cockroach haven in Texas. And then we have the pets, and some people, and the dander that's shown down in the bottom right panel, those also can serve as providers of outdoor allergens if they come in, and they can carry the pollens in with them. And so this was to remind me, to remind you that that's an important issue as to whether you have pets, whether they're indoor pets or outdoor pets. And if they're indoor, the recommendation, which I have to say I don't live by with all of our pets, is the advice is wash your pets at least once a week to get rid of the danders and the pollens. And then in the middle is the molds and the mold spores that can be a problem. And certainly these are, particularly the dust mites, the cockroaches, the molds, they are allergens that thrive on warm and humid weather. So we're just right for these being a year-round problem. So the clinical manifestations and the treatment for these are a little bit of a moving target. But the important piece, if you are having symptoms, is to what I call get some precision diagnostics, which is let's clarify what it is you might be allergic to, and then we can address the appropriate strategies for treatment. And there are a spectrum of those. But clinically, the manifestations span anywhere from the conjunctivitis and the runny nose, the congestion, and in some, as shown on the right panel here, this is looking up somebody's nose, and what's shown there are nasal polyps. So this can be complicated by both sinusitis with nasal polyposis, and then we have the lower airway involvement with asthma. So some people will have just the sneezing, itchy eyes, watery, runny nose, post-nasal drip symptoms. Others will be complicated by the sinusitis and nasal polyps, and others will have asthma. So the management is sort of the first thing is mitigation or avoidance. And we have a variety of strategies depending on what allergens that you might be sensitized to for how to mitigate. For those that are year-round, they are really dependent on particularly say mitigation of dust mites, and there are many strategies for that, including everything from how you manage your air cleaners and your air conditioning and heating systems to how you manage your laundry, how you decorate your home in terms of rugs and blinds, etc. So it depends on the specificity. So it is precision medicine in terms of defining the aeroallergens, whether they're perennial, seasonal, or a combination. And the treatments are really pretty straightforward in terms of antihistamines, because those are the histamines are the chemicals that are included in those that are released by the mast cells when they're triggered. And there are a variety of those. For a number of years now, we have the second generation and even third generation antihistamines that have minimal to no sedation and can be taken once a day and are useful, and they're over the counter for many of them. The inhaled corticosteroids, whether they're nasal or respiratory, are really one of the most effective ways to shut down a lot of the clinical symptoms, and many of those are over the counter also, and they're really fairly safe. Minimal absorption, and if you have just seasonal allergies, then you can limit the use of those just to the few months that your allergens might be at highest level. And then we have allergen immunotherapy. It is actually the only truly proven approach, which is injection of small amounts of allergen subcutaneously. It over time shifts your immune profile to one that is a non-allergen profile and is very effective. The other point I want to make is the exciting area of the new biologic therapeutics that are out there, the monoclonal antibodies that target specific molecules in the allergic inflammatory pathway. And while those are not currently directly approved for use of just aeroallergens, they are approved for a variety of compound allergic conditions, so that they're approved for a variety of subsets of asthma and for a variety of other allergic inflammatory skin diseases, such as atopic dermatitis. And so the observational studies have demonstrated that if you have concomitant aeroallergen symptoms and you are eligible to receive and benefit from these biologics, which are much more expensive, your allergic rhinitis symptoms markedly improve. So it won't surprise me at some point when these become economically available that they will be employed in effective treatments for the allergic rhinitis, and another addition to the armamentarium. Now, I would be remiss if I didn't touch on this, but I think it may come up later, And that is, I use this slide that illustrates one of the challenges out there right now when people say, are my symptoms due to allergy, pollen allergy, or do I have COVID? And so this Venn diagram is a little bit of a summary of the symptoms that on the left in the blue shaded area are more unique to COVID infections, and those in the on the right side in pink only would be those with the allergens. But allergies themselves do not cause fever, and so that's a clear distinction. Now, you might have bacterial sinusitis because you have underlying allergic rhinitis. But the key issue is when in doubt, test. Okay, so I'm going to move on now to some other things that we encounter in the summer in particular. And I'll just touch on a few of these, but certainly bees, vespids, which are your wasps, hornets, yellow jackets, are the stinging insects, which above and beyond the acute sting, pain and swelling and frustration, if you get stung, in the individuals who are sensitized and highly allergic because they've made high quantities of that IgE antibody to molecules in the bee venom or the wasp venoms, then you're the allergic person that one can then get specificity around what you're allergic to with the skin testing with the venoms, and then putting one on immunotherapy with the venoms. And then the other major culprit are the fire ants, illustrated crawling all over the boot there by somebody that kicked the fire ant bed. And those also have certain characteristics. Now, just a little pearl. This is an illustration of a honeybee sting. When they sting, they die. They get one sting on you, and then they have a barb on their stinger, and that sticks in, and they eviscerate their tail end, and there can be a little poison sac on it. So if you have a barb that's there, that's a honeybee. And if you would do best to try to flip it out, say with a credit card or something that you pull out with. Don't grab what'll have the end of it and have a venom sac on it. You'll squeeze more of the venom into the wound. And then the fire ant distinguishing feature is over the next day, you'll get sterile pustules that show up at each of the sting sites. So the management for a routine sting is pretty much just, it'll get better fairly quickly. If you have major symptoms, you can take antihistamines, but if you have anaphylaxis, the treatment is intramuscular epinephrine. And so those that are allergic sensitized, we make sure they have these. The keys around it are trying to identify what it was that stung you. Oral antihistamines, topical corticosteroids if it gets too inflamed, epinephrine for anaphylaxis, and venom immunotherapy is available. The other culprits that we run into out there during the summer are the various poison ivies, poison oaks, poison sumac. These are a different type of allergic reaction. They don't generally involve the IgE mast cell component. They're more of a T lymphocyte inflammatory response, and they peak over several days after exposure. It's an oil that you're sensitized to, the urushiol, and they're similar, so if you're allergic to one, you may cross-react with the others. Do not burst the blisters. You can get real skin exposure to bacterial organisms, and then when you go to the water, you don't get total freedom from these stinging challenges. On the top is the jellyfish, and these are common in our Gulf waters, And in the upper right-hand panel, I'm going to make some personal points here. That's my granddaughter, and we were playing in the shallow waters down on the coast at our bay house, and a jellyfish just wrapped around and got her on both legs, and she, I thought, was actually close to symptomatic anaphylaxis. Generally, though, this is a toxin from the stinging nematocysts that are in the tentacles, and there are some things that you do and things you do not do for these. The first thing is try to get the tentacle off. Don't rub it. Don't put sand and rub on it. All you're going to do with that, and don't put fresh, clear, fresh water on it. Those are all things that will stimulate the nematocysts to eject the poison. If you're going to take a little first aid kit with you to the beach, have some tweezers in it or some gloves that you can double up, and you pull off the tentacles and get them off of the individual. Then you wash the area with salt water that they're in, and then you can, if you have warm water, that is more effective. There's no good studies to document the validity of pouring vinegar on them or pouring meat tenderizer, but people tend to do that. The problem is you also tend to rub it, and that can create worse things. Some of the worst stings are with the Portuguese man of war, shown in the bottom left. Those are the ones that are commensurate, actually 4 different colonies of organisms that come together to form Portuguese man of war. The blue bubble, they're blown by wind. That's not got the nematocysts in it, it's just in their tentacles. They can sting much more severely, as shown on the bottom right. What I don't have here, and won't show you, but if you're traveling to other areas of the world, such as Australia and the Indo-Pacific, you have the box jelly, which can kill. So again, you have to know your geographic areas and what's at risk. And lastly, again, making this personal, this is me on the right. And if you don't know this critter on the left, you hopefully will not ever get to know him. That is known as the asp. It's the puss caterpillar of the flannel moth. It's cute. It's about 1 inch long. It comes in various colors, gray to white, and it's got spines, microscopic spines that are in 3 rows down across its whole back. And I was in my rose garden working on it, and I brushed against it, and that's the tattoo that it leaves. And I can guarantee you, it hurts like hell, and it itches like crazy. So with that, hopefully we've gleaned a few pearls for how to approach our summer. Thank you.
Well, thank you, Dr. Huston. I guess it certainly is a jungle out there. Give me a lot to think about, for sure. Well, those are all major issues in keeping safe in the summer. We especially want to keep you out of the emergency room. Nothing will spoil a summer vacation or the summertime like that, and we see a lot more people, unfortunately, in our emergency rooms with injuries and other things. So Dr. Gandhi is going to talk to us a little bit today. Hopefully you'll only see him virtually today. We don't plan on you seeing him in our emergency rooms.
Thank you, Dr. Boom, and thank you to all the members as well of our Society for Leading Medicine for joining us today. We'll be talking a little bit this morning about summertime safety. So quick agenda here this morning. As you guys know, in the ER we like to move fast, so we'll move pretty fast through these 4 topics as well. Would like to discuss some kind of local issues or things that we see here with heat-related illness. We'll also discuss some mosquito safety. And then we know that this is a little bit of a summer of reopening. A lot of folks will be traveling, so I do want to touch upon some travel concerns and travel items you might see, including exposure to some high altitude. And then finally, we'll close out with kind of what to keep and what to stock in your medicine cabinet and touch on some first aid kits. So heat stroke, you don't need me to tell you, I know we're only a few days away from the start of summer, but it feels like we've probably been in summer here in Houston for about the past 4 weeks or a little bit longer. Temperatures are frequently north of the high 90s or 100 degrees, heat index rising even higher. In these early parts of summer, it's especially important for us from a preventative standpoint to consider heat stroke and other heat-related illness and take steps to make sure that we can both acclimatize our body and really kind of avoid any more catastrophic illness. I know this is a little bit of a busy slide here, but this kind of really talks about a lot of the common heat illness that we see, especially in the emergency department. Effectively, this takes us through some of the pathophysiology. So as we're outside or as you spend time in the summer, whether you're active, walking, biking, perhaps playing some golf or tennis, or just working in the yard, as you're really outside and exerting yourself, you're exposed to some extremely high temperatures, and that causes quite a bit of high stress or heat stress on your body. The heat stress does a couple of different things from a physiological perspective. It starts to activate what we call our heat defense. So within your skin, you'll start to see a lot of evaporation. You'll also start to see what we call a vasodilation of your blood vessels. Simply that means your blood vessels start to get a little bit larger, and that's a normal response as your body starts to adapt. This can have a couple serious effects, namely being that you can start to get hypovolemic. That's just a fancy term for being dehydrated, losing a lot of fluids. A lot of fluids are kind of evaporating off. So it's not uncommon for us to see heat cramps. That's typically seen by salt and water loss, a lot of achiness throughout the body. We can also see some heat exhaustion as well, dehydration, episodes of what we call hyponatremia or low sodium. Finally, I think the two more worrisome things that really prompt visits to the ER are where we have heat syncope, which is passing out. So typically what happens is your body has this dilation of your blood vessels, you're losing lots of fluid, you might be exerting yourself. This is usually occurring in a fairly short period of time, and then you may have an episode where you pass out. And then we also see heat stroke, and heat stroke is probably the most concerning of this constellation of symptoms, which really can have significant what we call morbidity or illness, and unfortunately, as we've seen, or as I've personally seen a few times in my career, can be fatal as well. So heat stroke is a condition that's really caused by your body overheating. It's typically due to either one of two things or both things, which is prolonged exposure to the heat and then significant physical exertion and high temperatures. We see at times, especially weekend warriors, folks going for very long runs on the weekend, very long bike rides. They may start off at say 7, 8, or 9 a.m. The temperatures aren't that hot, but by 11 or noon or 1, as temperatures get extremely warm, they tend to get affected, and sometimes they can have that heat syncope or passing out, as we discussed, or ultimately they can have some heat stroke. This is more common in the summer months, although here in Texas we do see this probably 9 or 10 months out of the year. One of the hallmarks of this heat stroke is that your core body temperature, the temperature inside of you, rises to 104 degrees Fahrenheit or higher. So if we think about a typical or classic fever that you might see in a regular illness, we usually look at temperature readings of 101 degrees, 102 degrees. This is markedly different as your body tends to get extremely hot, and that rise or that rate that it rises is very short or it's very fast. This is primarily concerning because it can have a lot of catastrophic effects, initially starting on your muscles. Then it can lead into a lot of our organs, our kidneys, our heart. What happens is quite a few of your muscles will start to break down, and that can actually clog up your kidneys, and that can be very difficult for your kidneys to kind of filter out your blood effectively. Ultimately, this can affect your brain as well, and that's probably one of the most concerning findings. So with heat stroke, as we discussed, we can see patients, what will someone have? They'll typically have what we call altered mental status. So if we ask a family member or friend when they're suffering from this, what's your name? Where are you? Who's the president? Some basic facts and things, they may not really know them. We'll also at times see an alteration in sweating. So what that means is, normally when you go out, especially in our heat with our humidity, you'll sweat a lot. You'll start to have that evaporation that we talked about. as your body moves into heat stroke, sometimes you'll actually see the absence of sweating. You can start to see nausea and vomiting, very flushed skin, a rise in heart rate and rise in breathing, and some headaches. There's two main age groups which are primarily affected by this. So we can see this frequently in the pediatric population. Children are very small and they're quite sensitive as their bodies are still developing. And then we also see this with the elderly as well. If we think about the summertime, families gathering, spending time together, sometimes multi-generational. You may have grandparents, parents, children all together. Elderly folks are extremely susceptible to a lot of heat-related illnesses. For treatment, what we can do, if you have very minor symptoms, most of this can probably be treated at home with maybe some water, Pedialyte, Gatorade, some drinks which actually will help to increase some levels of sodium within your body. Frequently moving to a colder environment or a colder shower can be helpful as well. However, if you have any of the symptoms on the top part of the slide, those need to come to an emergency department very quickly. There's a lot of therapies that we can deploy in the emergency department which can help to reverse and really stop the progression of any kind of heat stroke. We use cooled IV saline, cooling blankets as well, bear huggers, different things to help take that core temperature and bring it down in a stepwise fashion. So with these symptoms, I would keep a very close eye on them, especially your loved ones and anyone else that you're with this summer. In addition to the summertime here, the heat that we see in Houston, we also get to see mosquitoes, as Dr. Houston was telling us about just a little bit earlier as well. So there's over 3,600 species of mosquitoes worldwide. For some reason, only 85 of these species live here in Houston. It feels like a little bit more. But so it's important to know what we can do, I think, to avoid these mosquitoes from biting us or reduce the chances of that. So at a high level, we can look at both insect repellents and insecticides. So insecticides are physically the agents which kill bugs or remove bugs. Those are typically provided by commercial pest control individuals, sprays, different agents that they may use within your house or around your property, around a business to help reduce the risk of mosquitoes. And insecticides, they'll actually kill them. Insect repellents are what we use probably more in our household, and those are agents which will allow us to really keep the mosquitoes away from us, and they're very important. So you may ask why. I know some folks will say, you know, why are we concerned about these bites? They're really just a nuisance. It's no big deal. That's probably the case for most bites, but there are some special considerations or things for us to take into account with mosquitoes. With our pediatric patients, at times they can get significant skin irritation from bites. Children especially tend to itch themselves quite a bit. Some of that itching can actually lead to skin infections. So it's not uncommon for us to see cellulitis and small infections from bites, or especially if there's been a lot of bites over a short period of time. Two more serious concerns that we have, or that we especially see in the emergency department, are both West Nile and encephalitis. Encephalitis is just a fancy term for an infection of your cerebrospinal fluid, so the fluid around your brain, around your spinal cord, and this is a virus which can be transmitted by mosquitoes. As we talked about traveling this summer, we know many folks are moving around the country, and some folks are moving around the world as well. So keep an eye out for other illnesses which are caused by mosquitoes: malaria, dengue, chikungunya, yellow fever, and Zika virus as well. A great resource is the CDC website has a tool called the Yellow Book. And if you type in CDC Yellow Book in any search engine, you can pull up a great guide which will allow you to look to the destination that you're going to and see if there's any chance for mosquito or other exposures or considerations to have while traveling. This slide here is actually taken from the CDC website, and it kind of shows us how West Nile is transmitted. So a mosquito is typically going to bite into an infected host, which is classically or commonly going to be a bird. From that, a mosquito will get infected, and then typically it'll spread that infection either to a human or to another mammal, commonly horses as well. There's no person-to-person transmission of West Nile, so that means if someone is infected with West Nile within your household, there's really no chance of them spreading it to you as it's spread by the mosquitoes. insect repellents, especially mosquito repellents, are a very, very effective way for us to reduce transmission of this. Unfortunately, here in Houston, we do see mosquitoes nearly year-round, so at times we'll see West Nile classically in the summer, but we can also see them off-season too. So what repellent should I use? I'd say one of the most common repellents that we have on the market is DEET. It's sold under the brands of Off, and there's a few other major brands out there as well. You can pick these up commonly at any drugstore, CVS, Walgreens, Walmart. So it's a very well-studied mechanism of an insect repellent. There's over 40 years of long-standing research on it. Historically, there may have been some concerns with pediatrics. There's older physicians sometimes have discussed about seeing high levels of DEET exposure with pediatric patients and seizures. That was based on a very small case series in the 1980s. A lot of that's actually been disproven in the past 20 or 30 years. Similarly with pregnancy as well, there's no association with any birth defects or miscarriage, and we know that DEET is quite effective. It's quite stable. If we recall from the Zika outbreak from 4 or 5 years ago, DEET was probably one of the more prescribed and one of the better agents to use. With any kind of DEET agent that you use, there's a percentage strength on the bottle. So that percentage strength, it's usually 10, 20, 30, 40, 50, can go all the way up to 95%. That percentage strength refers to the amount of time or the length of coverage that the repellent gives you. So 20% DEET is not necessarily more effective than 10% DEET. It just lasts twice as long. We do hit kind of a ceiling at about 50%. So while there are commercial agents which sell at 60%, 70%, 80% DEET, they don't really confer any additional benefit. Potentially, they may have more absorption issues as well, if that's something that you're concerned about, and they're not going to give you a really longer period of coverage. So a takeaway here, 50% DEET or less is probably good based on the amount of time you'll be in the sun. We've seen a major shift, I think, in our thinking and our habits and our decision making throughout our community as far as alternatives, and a lot of folks are looking for pharmaceutical alternatives or maybe some chemical alternatives. So they're asking for whatever else is out on the market. So some other good preventative measures are long sleeve clothing, making sure you're covered up during high mosquito peak season hours. Picaridin or icaridin is another medication or kind of another agent that you can use as well if you're DEET averse, DEET allergic, or DEET sensitive. And if you're looking for a truly natural agent, oil of lemon eucalyptus. This is something which has also been well studied. It has great efficacy for mosquito repellents. It's truly a plant-based alternative as well. One of the takeaways with oil of lemon eucalyptus, it only lasts for about 2 to 2.5 hours. So unlike some of the stronger percentages with DEET, which will last for 6, 8, or 9 hours, if you do opt to use a more natural agent, we would highly recommend that you continuously reapply it to your skin. Clearly, if you're in the water or other areas of moisture, you'll probably have to have more frequent applications. There is some talk or some discussion about other agents such as lavender, cinnamon. They have been studied. They're not particularly effective. For those of you who are looking for more wellness-oriented or natural products, the National Institute of Health has an amazing resource on complementary medicine, and they'll actually pull together a lot of different studies which have been done on different agents. So there's several studies out there on lavender. It's only 53% effective compared to DEET, so probably would not be considered a good alternative. Similarly with cinnamon, cinnamon oil, cinnamon essential oil, cinnamon agents, they're quite effective on killing the larvae or the immature mosquito, but really not going to be effective as a repellent. Shifting gears here, we know that a lot of members of our society spend some time in Colorado, and a lot of folks this summer will probably be headed to the mountains. When we go into altitude, we've got some physiological changes to be concerned about, as they can have a lot of medical issues and can cause a lot of symptoms. As we move to different altitudes or higher altitudes, the overall pressure starts to drop. As we see that drop in pressure, that has a profound effect on oxygen and kind of how oxygen is delivered into our body. We've got some common areas here in Colorado at Aspen, starts at about 8,000 feet, Vail's at about 8,100 feet, Breckenridge is at 9,600 feet. For those of you who might be going to Machu Picchu this year, Cusco, which is a town where a lot of trips emanate from, that's at about 12,000 feet, similar with Mount Fuji in Japan. And then for the true trekkers, we have Kilimanjaro in Africa and then Mount Everest in the Himalayas. Those are really at the 20,000 feet higher level. Anytime you go from altitude, especially living in a city like Houston where we're at sea level or sometimes below sea level, we can definitely experience a lot of symptoms. Some of the most common symptoms that we'll see are acute mountain sickness. This usually happens within your first couple days of travel. Really the hallmarks of this are headache, fatigue, loss of appetite, nausea, vomiting. It's been compared similarly to just like a bad hangover. Acute mountain sickness is classically limited and doesn't really have any other significant sequela from there aside from just kind of feeling lousy. Two other careful considerations for us are what we call HAPE, which is high altitude pulmonary edema. And this is not entirely uncommon. So this is something that we'll see in about 1 in 15 to 1 in every 20,000 travelers to an area of altitude. This has hallmarked by shortness of breath. So significant breathlessness, at times being unable to walk, having a cough, and seeing significant weakness as well. The treatment for a lot of our altitude illnesses will initially be oxygen. So if you're having shortness of breath while you're at altitude, would recommend at that point to definitely go to an emergency room or an urgent care. They'll probably get you lined up with some oxygen therapy. And then for many individuals, based on your symptoms, they may also recommend a chest x-ray and they may recommend some descent. Finally, the most concerning thing we see at altitude is what we call HACE, or high altitude cerebral edema. This is hallmarked by drowsiness, confusion, ataxia, which is difficulty with your limbs and walking, and some altered mental status. If you have any of these symptoms, we really need to work on immediate descent quickly. We see a lot of these symptoms, especially when patients are moving quickly, like a lot of patients may work here in Houston for the day. They may take an evening flight up to some altitude, and the next morning they may start off on a long hike, or try to ascend a mountain, go up to even higher elevations. The rapidity of that at times can cause a lot of different changes. So if you have any pre-existing medical conditions, congestive heart failure, MI, previous heart attack, sickle cell disease, I would be very, very cautious and take your time when you're ascending. For patients with sleep apnea, we'll talk about acetazolamide here in a moment. It's a prescription medication, which is given by your physician, but it can help to kind of shorten your course or blunt some of the symptoms of altitude. With altitude, as we talked about, we see a reduced oxygen content, so we get a lot of this high altitude periodic breathing, some rapid shallow breaths, some sleep disturbances as well. I would also be cautious while you're traveling within the first 48 or 72 hours to be very careful both with alcohol and also commonly prescribed sleep medications, particularly Ambien. At times, those medications or alcohol, they can actually stop or blunt some of your body's natural ventilatory response, and they can make you feel a little bit worse. So just some key takeaways here. Ascend gradually to about 8,000 feet. Less than 8,000 feet, we don't see a lot of symptoms. So for those of you who are traveling to, say, the Carolinas or spending some time in Montana, where a lot of the mountains are a little bit of a lower range, it's unlikely to get the more severe symptoms. Once you get to about 10,000 feet or higher, they recommend really going no more, or ascending no more than about 1,600 feet per day. Avoid alcohol initially, as we discussed. Caffeine is actually okay. There's some great research that says you can continue that. As with everything in the summer, make sure you drink plenty of water. And if you want an agent to help with any sickness, if you've been to altitude before and you felt unwell, you can highly consider Diamox. Diamox is a prescription medication. It's not recommended for patients who have had kidney failure or any kidney issues, so it needs to be prescribed primarily by your primary care physician, or a virtual care physician could help as well. It's a short course to get you to where you need to be. As we wrap up here, did want to discuss some first aid kits. It'll kind of tie together some things that we've been talking about, and also just discuss what to make sure that you keep in your home medicine cabinet. We're aware that a lot of folks are spending extended time away from home, whether they're on the road. Some folks may also have vacation properties or be spending time away from their primary residence. So make sure you keep a first aid kit with you when you're traveling. As Dr. Huston mentioned just a little while ago, there was quite a few things that a first aid kit can help with gauze, tweezers, scissors, pulling out maybe some bites, helping with some local issues or redness. As we think about stacking our medicine cabinet, what to kind of keep in there would be, I would say, 3 main things that you should have with you at all times would be acetaminophen or Tylenol, ibuprofen or Motrin, and then Benadryl. Here's just some common doses. This is a question that I get frequently from our friends. Hey, I've got a fever. What dose of Tylenol should I take? Hey, I've got some joint pain. Am I taking enough ibuprofen? So for acetaminophen or Tylenol for fevers, about 1,000 milligrams is a standard dose for fever, really no more than 4 doses per day. If you're using Tylenol for pain relief, you can use 500 to 650 milligrams. For pediatrics, the dosing is 15 milligrams per kilogram. The good thing is nearly all pediatric formulations will have dosage written on the bottle, and they also will have little droppers or small cups as well to help you measure out the exact amounts that you have to give. With ibuprofen, standard dosing is 600 to 800 milligrams. It does have a little bit of a side effect profile with can cause some stomach issues, so be cautious if you're taking it for more than 3 or 4 days. And then with Benadryl, 12.5 to 25 milligrams for an allergic reaction is a standard dose. In addition, these are some other things you may want to keep in your home medicine cabinet as well, with some aspirin, hydrogen peroxide to help clean out any cuts, to help clean out any bites, hydrocortisone cream as well for any rashes, and then finally standard stuff with Tums and Pepto-Bismol. All right, these are just some references to the back. Thank you.
Well, thank you, Dr. Gandhi. I appreciate that very much. Lots of practical advice today, and we really appreciate all 3 of you. In the interest of time, I'm going to kind of go one by one here with some questions. I'll just start with you. We've had a nice string of questions coming in. 2 for you. The first is when you say descent in 2 of those conditions,
Yes.
HAPE or HACE, that you were talking about. What does that mean exactly? I mean, if you're at altitude, does that mean get back to sea level? Does that mean go down a certain amount? What would you usually recommend in that?
Yeah, that's a great question. So when you're descending, I think it depends upon your symptoms. For most individuals with the acute mountain sickness, as we talked about earlier, that's going to be self-limited. With the HACE and the HAPE, they would recommend descending at least about 3,000 to 4,000 feet. Typically, when you drop to about 6,000 or 5,000 feet, you'll start feeling better almost immediately. There's a tremendous amount of case reports, especially from the Colorado area, of patients, if they make the drive back from, say, Breckenridge or Aspen down to Denver or somewhere lower, their symptoms frequently resolve in that time period. So usually within a couple thousand feet of descent, you'll feel better.
Good. Okay, well, thanks. That's very helpful. And then, a question I get asked a lot, and there's always a lot of discussion about, and in the heat, very relevant now, keeping hydrated, rehydrating. Is water fine? Do you need electrolyte solutions? I mean, when would you use each? What do you think about those differences?
Yeah. So from what we've seen, if you have a well-balanced diet as a baseline, as long as you just continue to drink water, probably with a recommendation of 2.5 to 3 liters per day, that should be sufficient for an average person. Now, everyone's body is a little bit different. Some individuals are a little bit more sensitive. There's no contraindication, means there's nothing to say no or don't use a sports drink or Pedialyte, and that can be beneficial in some situations. But just in general, regular water is going to work fine for most people. Absolutely.
You don't necessarily need to pay attention to all the marketing necessary for all of that. You might enjoy drinking like my kids do, but water is usually adequate.
Absolutely.
So, and a rule of thumb, if you're out in the heat exercising, how much water, how quickly, when do you do that? Do you wait till you start feeling thirsty? Do you get out ahead of it? Give us some rules of thumb for that.
Yeah, no, that's fantastic. I think a key thing with water consumption is to make sure you hydrate plenty even before your activity. So upon arising or waking or in the morning hours, even before you get outside, if you can drink about half a liter to a liter, that'll help you get better. By the time you're feeling thirsty, unfortunately, it's probably a little bit too late. That indicates at least a minimum of 20% dehydration. Even if you are consuming water at that time, it's probably going to be difficult for your body to get back into a normal stasis.
Great advice. Thank you. Well, I'm going to turn to Dr. Shah. Lots of questions about sunscreen. Let me start with one, which is they're kind of interwoven. Talk about mineral-based or natural sunscreen, and part of that is, are they better? Who should use them? The other piece is a question of, well, you're worried about all this UV exposure and it being a carcinogen. Do we need to worry about anything that's in any of these creams that we're putting on, or sunscreen sprays and other things? Do we need to be worrying about that as a carcinogen?
Yeah, well, that's a loaded question, and so you've got your chemical sunscreens that have all these different chemicals, and you've got your mineral sunscreens. Your mineral sunscreens are basically on the skin, and they're reflecting the light, so they're providing just this little level of where it's basically like having something that's preventing it from going through.
So
it's
zinc oxide would kind of be the classic. Zinc oxide would be kind of the classic.
Like zinc oxide and titanium dioxide.
Okay.
Honestly, those are my favorites. I love zinc oxide, I love titanium dioxide, and I usually recommend a physical sunscreen. It gives you a little broader spectrum, and you don't worry as much about sensitivities. And what usually happens is with the chemical sunscreens, you end up getting, it forms a chemical reaction with your skin. So it's not just bouncing off the sun rays, it's a chemical reaction with your skin. So then you end up with the possibility of allergic reactions and sensitivities. So I like typically the mineral sunscreens, but you know what, honestly, the best sunscreen is one you'll wear.
That you'll actually
and
use.
That's what I tell people. I said, if you find one you like, that's what you're going to use. But if I had to pick, I like the mineral sunscreens. Don't worry about sensitivity to the skin. And carcinogens and whether they are dangerous for, the coral reefs and our body, that's kind of, that's a question that probably can't really answer right now because it's a loaded question, but
Okay. Great. Well, that's very helpful. So, maybe I heard a lean there towards some of the mineral-based for sure.
Love the mineral-based sunscreens, and especially you can have it around the house, kids, everybody can use it. And now we've got these elegant zinc oxide. Right. They're micronized, they're elegant, and so
and what you mean by that is I have pictures as a kid of the lifeguard with the big,
thick
yellow or white nose.
No,
nowadays
now it rubs in.
It's not that way. It rubs
exactly.
in. Yeah.
Rubs in easily. You don't worry about it. And then for people that do worry about chemicals on their skin, then you don't worry about it quite as much.
So a kind of a related question. I mean, I think of my wife and me. My wife wears makeup, and a lot of her makeup has some sort of SPF factor, so she's kind of always got some protection. I don't have that kind of protection. There's questions about, should we be routinely and automatically applying, or only when we know we're going to be in the sun? We're in Houston, where we get obviously a lot of sun. So.
Yeah. So I tell all women, you cannot rely on what's in your makeup. When we're putting makeup on, we're kind of like putting it on and a little here, a little there. Do not rely on what's in your makeup. So I usually have them use a sunscreen first thing after you brush your teeth. Put your sunscreen on. You don't know if you're going to be driving for 20 minutes in the car. We talked about it coming through, the windows. You may think you're going to be inside, but then you go take the dog out for a while. Right. And sun exposure is cumulative. Mm-hmm. Right.
Well, that was a question that's a great segue. Somebody asked, well, I'm a little older. It's all about lifetime exposure. Is it too late? Should I use this at any age? So
exactly, and we don't know. It is cumulative, and the skin does not forget, like an elephant. It does not forget. So it is cumulative. Yeah, is it too late? If we knew how close you were to that tipping point, then I'd say, maybe you are, maybe you aren't, but we don't know.
Okay. So keep using it, in other words.
The recommendation
it's never too late to start if you haven't.
Not just keep using it, but teach the children.
Yeah, for sure.
Because we can't go back and undo that. We can't. We cannot go back, and I have folks that are like in their late 30s, and they're just like, well, I'm getting all these skin cancers, and, damage has obviously been done.
And one last question. How much SPF Because we get that all the time. We got that here across the screen. How much is
30.
enough? 30.
I like a 30. Anything 30 or above.
Is it better to do a 50 or a 60 or a 70?
There's no.
Kind of like DEET.
Yeah, after 50.
I saw you nodding when we were talking about DEET. So same thing. There's sort of at some point it's more of a marketing ploy to just get people to buy.
Absolutely,
Okay.
absolutely.
So,
And one other thing, and I think I saw a question come in about this, is combining your repellent with your sunscreen. We don't recommend that because, again, you don't know how much you're getting of this, how much you're getting of that. And so we do not like, I don't know how you feel, Dr. Gandhi, but we do not like the products that have a combination of insect repellent and sunscreen in it. We say each one needs to be its own
separately.
thing.
Yeah. No, I would 100% agree with that, Dr. Shah. And also, while reviewing a lot of research that's been done, a particular sunscreen agent called oxybenzone, which is fairly common in a lot of sunscreens, that has been known to synergistically increase the amount of DEET and oxybenzone toxicity within your body. So if you're using an oxybenzone agent and a DEET agent, probably use either a little bit less or give your body a little bit of a break between applications.
And that would be a chemical
That'd be another
sunscreen.
chemical
so.
And the one last thing I'll say about SPF, I mean, I worry that when people put on a 60 or something like that, they just think it's going to last way longer.
Right.
It really doesn't, right?
Right.
So that's
Right.
it's more important to get that reapplication, be 30 and above.
Absolutely, absolutely. It's more important to get the reapplication and also be careful of having a false sense of security.
Right.
I mean, people put it on and they're like, basking, and then they come see me and they're all red and they're like, well, God, I knew I was, coming to see you and I tried to put my sunscreen on. Yeah, exactly. That's a false sense of security. You reapply and don't just rely on
Pay
that
attention
part.
when you buy. Don't buy the cheap stuff, because I did that one year. All my family got sunburned. I got chewed out by the whole gorilla for a while. Lastly, Dr. Houston, actually, I'll get to allergy questions, but a couple kind of around this COVID allergy sort of piece. You talked about COVID versus allergies. People asked about COVID versus flu. Is there any way to sort that out, or is that just a matter of getting tested? And then somebody else asked about having had a sinus infection not long after they had COVID testing. And is any possibility that was related, or is that probably coincidental? He's speechless.
I'm
Okay.
speechless. No, the point of comparing or contrasting symptoms that might be COVID-related versus allergic would apply to any infectious problem that impacted, in particular, the respiratory tree. And so I think those are you could for many of those symptoms on the COVID side, you could substitute flu.
Yeah, okay, so pretty much
So-
indistinguishable. Largely,
Yeah, but-
smell and taste would be something that's pretty specific to COVID, probably.
Well, not necessarily.
Not even that.
The people with significant allergic problems, upper airway problems, and particularly with sinusitis, they'll have problems with smell and taste.
So if in doubt, get tested.
If in doubt, get tested.
Yep, okay. And it's quick and easy now, thankfully, to do that. Okay, and then the last thing I want to ask you about, people interested in their home environment. If there's somebody who suffers from some allergies and, maybe they've gotten that specificity of understanding that it's home related, how do you tackle that? What are the kind of 2 or 3 key things someone should do, and maybe all of us should do with our homes to think about avoiding allergies?
Well, the answer to that is, I'm going to take it back to what is it you're allergic to? And that's where the testing comes in for providing evidence-based advice. So there are specific strategies if you are in fact sensitized to the dust mites. And there are, but I'd say in general, if it's roach, then you need to be very aggressive in terms of your roach hotels, doing things to eliminate those. But people sometimes say, well, I'm allergic to dust. Well, dust is I'm going to say it's the ground up garbage in our environment, and it's it doesn't need to be a whole roach. What it is the proteins from roach fragments, and they die and they end up getting into your ventilatory systems. So, it depends on what you're allergic to as to what are the best mitigation strategies, and we have recommendations that are specific for each of those.
So I think really embedded in that is, if you're more than run-of-the-mill allergies, not kind of controlling it relatively easily, get tested and figure out.
Get tested, identify what you're allergic to, and then if it is perennial, then we have specific mitigation recommendations
around that. Well, thank you. Well, a lot of great advice. Thank you to each of the three of you. Hopefully, all of you will help us enjoy an even better summer, and really appreciate each of you being here. So thank you very much. I'm going to move on, briefly talk about just one highlight that happened at Houston Methodist while we're kind of getting set up here with our next speakers as well. Thank you for bearing with us. We are going to talk about both monkeypox and COVID coming up, but I wanted to just deliver a thank you and deliver an update on something special that happened this week, and that is that the Gerald Katz Foundation actually gave a grant to Houston Methodist to create the Humanitas Award. This was targeted for the people at the institution who were behind the front lines, really helping others throughout the pandemic deliver great care. And over 4,000 of our employees received a financial bonus, as well as a beautiful certificate you see on the left, as well as an incredibly lovely description from Evan Katz, and a thank you from Evan Katz of what they had done and achieved throughout the pandemic. On Wednesday, we actually had a celebration here where several hundred of those individuals came through, were able to get pictures with Evan and others of us. Just lots of smiling faces, lots of opportunity, and really countless powerful stories from these individuals. Throughout this pandemic, the support of the public has been so amazing and so helpful to us, from the meal deliveries to the well wishes to social media campaigns to donations like this. And I just wanted to say thank you to all of you for all of your support throughout all of that time, and a particular thanks, of course, to Evan Katz and to the Katz Foundation for creating something this really remarkable. With that, I'm going to now transition to our next speaker. We have Dr. Ashley Drews, who's going to give us a very brief update on monkeypox. Knock wood, thankfully we haven't seen that here in Houston, Texas, but it's probably only a matter of time, and we know you have many questions, and we'd like everybody to be able to hear a quick overview of monkeypox. Dr. Drews. Technical issue? We'll flip if we need to.
All right, can you hear me now?
Dr. Drews, we can hear you.
All right, great. So, are my slides available? I just wanted to say, as my grandmother used to say, if it's not one thing, it's another. And, we've been worried for over 2 years now about an RNA virus, the coronavirus. And now we've all been hearing about monkeypox and, concern about monkeypox. Which is a DNA virus. So I wanted to walk you through today a little bit and just let you know, what is monkeypox? How do you get it? How much are we seeing here in the United States? Is it something that I need to worry about personally? And if you could advance to the next slide. And actually, I'm not seeing the slides. So I'm not sure what we're looking at, but I wanted to tell y'all, there we go. Now I am. Thank you. So as I said, I wanted to share with you first a little bit about what monkeypox is. And monkeypox is an infection, and it is caused by a virus that's in the same genus as variola. And variola is the virus that causes smallpox. So obviously that sounds really scary, but I want to walk you through this a little bit more so you'll know how much level of concern we should have. Monkeypox, like smallpox, causes a rash. It's very similar to smallpox in its classic form. So monkeypox was first isolated from a colony of sick monkeys in the late 1950s, hence it developed the name monkeypox. I'm sure some of you have heard that is a lot of discussion about maybe renaming this virus at some point. So we'll see. Maybe it won't be a monkeypox outbreak for long. It'll be something else. But monkeypox is actually believed to have infected humans in sub-Saharan Africa for thousands of years when they look back at history and reporting. So it's something that we've known about for a short period of time, but has probably been here and infecting people for much, much longer. There are two distinct strains of monkeypox that exist in Africa. They have different geographic areas where they are distributed, and these different strains have different virulence, meaning how aggressive they are, how sick they make you, and mortality rates. There is a West African clade that has lacking some of the virulence genes and has been classically associated with a mortality rate of about 1%. Fortunately, what we see circulating right now in the current outbreak is related to that West African clade, so less virulent. And then there's a Central African clade that is more virulent and is associated with mortality up to 10 to 11% classically. Next slide, please. So how do you get monkeypox? So who is at risk? And I'll say that anybody can get it, but there are ways that we can try to protect ourselves. So we'll go through that. The most classic way is animal to human transmission. It is typically acquired by contact with an infected animal's body fluids or a bite from an infected animal. Also, if you touch the skin or the bedding from an infected animal, then you might acquire the infection that way. And that's been the classic way from these African cases that has been transmitted to humans. Unfortunately, it can transmit human to human. And usually that requires really close contact with infectious skin lesions or the lesion material. That's the most classic way that it is transmitted. And during this current outbreak, I'm sure you may have heard, but it seems to be particularly seen in men who report having sex with men. And there's a thought that maybe there's contact during sexual contact, and it may be transmitted that way during this outbreak, which is different than what we have seen in prior monkeypox outbreaks. There is the possibility of it transmitting by respiratory droplets, and it has not been shown to be transmitted by aerosol routes, but in an abundance of caution, when we're dealing with patients that have monkeypox, we still use that type of protective equipment for that possibility as we're still evaluating this new outbreak that we're dealing with, just to be on the safe side. Next slide. So where is monkeypox right now? As I told you, historically, most cases have occurred in Central and West Africa. It was first seen in the Western Hemisphere in the United States. Actually, in 2003, it was pretty neat for infectious diseases and, doing some detective work. It was an outbreak in the Midwest, and they were able to track it down to pet prairie dogs. So, not something that the rest of us are exposed to. That was a very limited exposure there in 2003. Since that time, we have seen sporadic cases in travelers from Africa, but not cases that are ongoing outside of that travel exposure. So what we're seeing now is different than what we've ever seen before. In May of 2022, so just this past May, multiple cases of monkeypox were reported in Europe, both in Spain, Portugal, and the United Kingdom, in travelers, but then also started to be reported in people who did not have any travel history, but maybe with exposure to these other people. So it became clear that there was some ongoing human-to-human transmission, in those locations. The first case here in the United States was reported on May 18th in a man in Massachusetts who had traveled from Canada. And so really what we're seeing now, though, is a lot of dramatic escalation. Just yesterday, when I looked at our CDC website, there were 84 cases in the United States, and now this morning up to 100 cases. So you can see that it is, starting to grow a little more rapidly. It's in 21 states now. Worldwide, there are over 2,000 cases in 37 countries. So it is certainly different than what we've seen before, where it was limited to Africa and, travel exposure. Next slide. So what is monkeypox? What disease? How do people present? How would I know if I had it? So it is not a specific viral prodrome. So usually about 1 to 2 weeks after exposure, but anywhere really between 5 and 21 days after you've been exposed to the virus, people classically will develop very non-specific symptoms of, having an infection, fever, chills, myalgias, which is, our word for muscle aches, headache, exhaustion, swollen lymph nodes. And then a couple days after that, there's the classic rash. And so classically with monkeypox, it is a rash that started on the face and then will spread to the rest of the body and include the palms and soles, which is pretty interesting to us in infectious diseases because there's not very many rashes that will actually involve the palms and soles. So that has kind of been a classic hallmark of monkeypox. And the lesions tended to progress very typically. So they would start out with kind of flat red bumps, macules, since we're talking dermatology. Then they would become palpable where you can feel it. They're raised. They would become fluid filled like a vesicle. Then there would be kind of the yellow fluid like a pustule. And then they would become harder and slough off and form scabs. And typically that would all happen at the same time. So any one person would have only macules and then only vesicles and, progressing in the same stage. What people are finding with the current outbreak is it's not following those same patterns. So patients are not necessarily presenting with the rash on the face first, and they may have lesions that are presenting in various stages. So any one person might have a macule and a pustule and a vesicle. And so that looks a little bit more like what we see with chickenpox, and it's harder to discriminate. And so just like we were saying you can't really tell between COVID and allergies necessarily, or you can't discriminate always based on symptoms between coronavirus and influenza. Same thing with monkeypox. You don't know for sure when you're seeing somebody. And so we need to do testing, and we diagnose similar to COVID with PCR. Currently that PCR testing is done, solely through the state health lab. But you take a swab from the lesion, you can send it off to the health lab, and their turnaround time, they say, is going to be within a couple of hours. As you know, we have not had a case here in Houston yet. There's been one case in Texas, only in Dallas. So we haven't, tested the system yet, but we're prepared. We're ready to do it if we need to. Next slide. So what about people if you do get monkeypox? So as I said earlier, what we're seeing right now that is circulating, the virus is much more closely related to that West African clade. And so that classically has lower mortality, down to about 1%. There have been no reported deaths so far with this current outbreak. So that is reassuring. Most people with monkeypox have really mild disease and they recover without any specific medical intervention. Some people may get dehydrated or need some IV fluid or other supportive care, but most people really just, they have to quarantine at home so they don't transmit it to somebody else. But outside of that, they don't need any specific therapy. Obviously, there are some people who may have more severe disease. Maybe they're at higher risk because of pregnancy, they're immunocompromised, other health conditions. And, those are the people that would be considered for additional therapies. And so similar to COVID, you remember that we were giving convalescent plasma. So we can give immunoglobulin for monkeypox. And so vaccinia is the virus used to make the smallpox vaccine. And that has been used in some people, immunoglobulin from vaccinia, to try to treat people who have monkeypox to minimize their manifestations of the disease. And another thing that's very interesting with monkeypox is after you've been exposed to monkeypox, so even after you can be vaccinated. And currently there is no specific monkeypox vaccine, but smallpox vaccine does have some efficacy. And you can give the vaccine after exposure, and it may still prevent you from ever developing the disease, or it will make you more likely to have not a severe disease. So that's very different than most infections. You remember with COVID, we were telling you need to get your vaccine at least 14 days before you really realize your benefit. So it's different with monkeypox. monkeypox, you can actually use the vaccine as a therapeutic after exposure to try to prevent you from developing severe disease. And as far as antiviral therapy, there is currently no specific antiviral that is approved for monkeypox, but there are some agents for smallpox that have been used in some of these high-risk individuals with monkeypox. So there's an antiviral called tocilizumab, and it's an inhibitor of the orthopox protein. So these are orthopox viruses, and it has been approved for treatment of smallpox since July of 2018. And it's been studied in non-human primates and has protected them from lethal monkeypox infections. So, it has not been studied robustly in humans yet. It is available through the CDC. So, if physicians had a patient they wanted to try it, they could reach out to the CDC, and on a, case-by-case basis, then that might be offered. There are some other antivirals that are approved for other indications, cidofovir, which is used for some herpes viruses and cytomegalovirus. It also has some in vitro activity against monkeypox, but has a lot of adverse events. So not something, again, most people get better without any particular intervention, but so this would be reserved for those high-risk individuals. And then there's also brencidofovir, which is an oral analog of cidofovir, which also could be considered in these cases. And I think that's all I have. Next slide. Oh, no, prevention. Yes. Sorry, that's most important. So vaccine, just like we've been talking about with other infections. So there is, as I said, no specific vaccine for monkeypox yet, but smallpox vaccines have been shown to be have some efficacy against monkeypox. So vaccinia, so people who is the prior smallpox vaccine. So those of us who are a little more mature in age and have had smallpox vaccination before, then that has been shown to have protective effect in prior monkeypox outbreaks. For example, the one with the prairie dogs, it was just the younger people who had those pet prairie dogs that were infected. People who had been vaccinated previously with the smallpox vaccine were much less likely to develop monkeypox infection. So it may prevent you from getting the disease at all, and also it might minimize the clinical manifestations of the disease if you do. There is a modified vaccinia vaccine. It's a newer one called Imvamune or Genios. It was approved in 2021 for some lab workers who are at high risk for exposure to orthopox viruses. It's very limited in availability, but obviously people are looking into, ramping up the access to that vaccine. As I said, because people who have been exposed, it can be offered to them to try to prevent them from developing the disease. And that's all that I have. Thanks.
Well, thank you very much, Dr. Drews. Fortunately, I think one key message in there that you've talked about is this has been mild. It has been mild in everybody. It is not exploding out there, obviously, but it is something we've not really experienced before. So we'll watch it closely, but in general, we don't believe significant cause for general public to be alarmed or to be concerned that we're going to see a COVID-like situation. But speaking of COVID, unfortunately, we are in the midst of another surge. It's a very different surge than we've seen before, which I think actually is definitely some good news right now. And backed by popular demand, we have Dr. Dirk Sussman today, who is going to walk us through kind of the status of what's happening now and some changes that have happened in some of the science around it as well since the last time he's been here. Glad to see you, Dirk.
Thank you, Mark. Happy to be able to talk to folks again, but not too happy that it's because of COVID. So the question I'll try to answer is with a little levity here. Are we going to basically do the karaoke version of last summer, where everybody was like, yeah, let's have parties, let's go travel, and then we got hit with this big surge? And I think the answer is both yes and no. As Mark said, we're clearly in the midst of a surge. If you look at that top left panel, you can see that the wastewater burden of virus is 500% compared to about 900% at the peak of the Omicron disaster. The testing positivity rate is way, way up there, totally consistent with all the previous surges we've lived through. But then if you look at the top right and the bottom right panels, those are the hospitalization rate on the top and the death rate on the bottom. And you can see those are not following precedent, which is really, really good news. So it's out there. It's all over the place. I'm sure you know somebody or some buddies who have had it recently or have it now, but the severity seems to be way less. And we're seeing this in the Houston Methodist COVID data as well. We have about 171 inpatients. The ICU census remains quite low. Of course, these being lagging indicators, we do expect that these are going to get worse, but we're very hopeful that they won't get anywhere near as bad as the previous surges. Why is this? Well, Omicron does appear to be somewhat less severe intrinsically, probably because it prefers to live in the nose. But also, if you think about it, probably somewhere between 80 and 95% of the population has some level of immunity against COVID. And we may be, vaccine-related immunity, infection-related immunity, and in fact, those two things are independently additive. So hybrid immunity does turn out to be really, really effective. And what we may be seeing is that COVID starts to act like the common cold. You get it, you're immune for anywhere from a few months to a couple of years, and then you're susceptible to get it again with that same virus. The big wild card here, of course, is whether the virus evolves another huge mutation that breaks through therapies, breaks through previous immunity. And I think the bad news here is that most experts believe that the virus has got a lot of space that it can mutate into and still be an effective infectious agent. So we are probably not done with COVID from that standpoint. And I think the kind of somewhat disorganized and may I even say lackadaisical approach of the government and the pharma companies that has me worried. Vaccines and boosters. This is some data that was published in the New England Journal of Medicine yesterday from the country of Qatar, which has, incredibly good data. Bottom line here is previous infection with any COVID variant gives you about 50% protection against infection, and better than that protection in the 70% range against serious disease with BA1, that's the original Omicron, or BA2 and all of its progeny. 2 doses of vaccine, still pretty good for severe disease, basically worthless against infection. You really ought to get your 3rd dose. Really, really ought to get your 3rd dose. Once you're vaccinated or have previous infection, you can kind of substitute an infection for a dose of vaccine. It's not really true. They are very, very different in how they act in your body, but from a standpoint of how protected you are, it's a rule of thumb. Of course, 3 doses of vaccine and a previous infection, or a 4th dose of vaccine, and I'm referring to some data from Israel, do appear to provide additional protection. And the drug companies are now testing hybrid boosters, which do appear to provide better antibody levels against Omicron. The fine point here, and it may be a really important fine point, is that this is a BA1 based booster. It's based on the original Omicron variant, and they're testing the antibodies against the original Omicron variant. Data that came out in the journal Nature very recently seems to indicate that infection with BA1 does not help you very much against BA2. And of course, that's mostly what we have now, as well as BA4 and BA5, which also don't seem to be very well handled by BA1 antibodies. So for everybody who's waiting to get a booster in the fall because the hybrid boosters are going to come and save us, if you're at all at risk, I'm not sure I would wait. In the future, I think what we've got to work with is tailored boosters. We are really not well organized in terms of doing this. From a science point of view, you could do a new booster for a new variant in a couple of months. The science point of view, the commercial point of view, and the regulatory point of view are probably adding up to a cycle time of more like 9 months, which I think is really, really bad for COVID. And just fundamentally, it's the same game we're playing with the flu, and it's a game of catch-up. So it's not ideal because you have to guess about what the virus is going to do. The Novavax vaccine is probably going to be approved for emergency use pretty soon. I don't think this is a game changer. And newer vaccines like nasal vaccines or the pan-coronavirus vaccines are at least a year away. Treatments, no time to go into this in any detail, but man, this was, remember when we showed this graphic back in 2020 and it was basically a hope and a prayer. And now we have a lot of treatments that have some decent effectiveness against COVID and some continued research and potential agents. So good news here. In line with the staying safe this summer theme, remember that COVID is a respiratory infection and you get it mostly from breathing in particles that contain virus. You can get it from your hands, it's a minor route. You can get it from people coughing directly into your eyes, still a somewhat minor route. What you have to protect is your respiratory passages. You can do this by filtering the air. You can do this by opening the windows. You can do this by wearing good quality masks. And I stress good quality masks, and they have to fit well. You know, the cloth masks that I see most people using are better than nothing, but frankly, they're not really very good. And as always, you know, just try to think a little bit, use your common sense. You know, they say like, you know, well, outdoor activities are great. So the outdoor activity on the left is a weekend party at the Miami Grand Prix this year. And, you know, you have your somewhat more wholesome activity on the right, which is clearly going to give you a less risk of coming home with COVID. So, you know, kind of size things up. And I sort of do this common sense thing, you know, there's some data, the public health data is not great, but I thought maybe, and frankly, this is an anecdote, okay? But it's an anecdote that's backed up by some data. I thought I would tell you like what I do, because I have not gotten COVID in 2.5 years. So for whatever that's worth, I'm 73, I'm at high risk for that reason, but I'm not super, super high risk. So my mantra is enhance your immunity, minimize your risk of exposure, and if you do get exposed, try to minimize the amount of virus that you breathe in. And I have not given up with life. I've been to Europe 3 times. In the past year, I go to the East Coast to visit my grandchildren every month. I've been to Central America. I go to the gym 2 or 3 times a week, and by the way, gyms are incredibly dangerous places. I go to restaurants probably every week, but I never go indoors. I visit the grandchildren every month, like I said, but their other grandfather is older than I am and a little frail, so they get tested every week before they go to see him. So I go to all my normal meetings. I rarely wear a mask at those meetings, see friends and so forth. It's a decent life. Precautions: vaccinated, double boosted, eat well, make sure you take your vitamin D supplements so that it's normal. More than normal doesn't appear to be helpful, and frankly it's a little controversial in the medical literature, but I figure it doesn't hurt. Try to sleep well, and of course that's a joke, in a job like mine. I wake up at 3 o'clock in the morning worrying almost every day, but try to sleep well. If you're going in a public space indoors, use a good quality ear loop mask. Wash your hands. A little controversial or a little judgment call here, avoid large indoor gatherings. I don't go to weddings. I've had a couple of people, get a little offended about that. I don't go to medical conferences. I could tell you stories about the number of my colleagues who go to medical conferences and come back with COVID. It's incredible. And in risky situations, like if you're going to be, sitting at the gate of an airport, wear an N95 mask. So maybe just as examples, I give no guarantees here, but just as examples, maybe this could help you kind of calibrate the way you think that you want to live your life and how you want to protect yourself. But basically, our story to you is you can stay safe and you can have a great summer. And from all of us to all of you, get out that karaoke machine and have a great summer.
Well, thank you, Dirk. I think if I had to summarize, we're in the midst of a surge. It's acting differently. Thankfully, the virus seems to be milder. We have lots of immunity out there. But everybody should still be assessing their personal risk, which is what you were showing that example of. And then, not acting like it's just totally normal out there, but just adapting even just small amounts, again, depending on your individual risk profile.
Right.
Is that a fair summary?
Exactly right.
Good. And I got a question across the texting here about, are we going to go into lockdown again? Definitely not.
No way.
I don't see anything like that.
No way.
There's really no reason whatsoever. And in fact, to your point, with the twist at the end, we can act fairly normally with some adaptations.
You can have a good summer.
I've traveled a gajillion times this year via airplane, but I'm wearing a mask when I'm sitting for 3 hours next to other people. Minor accommodation, right, at the end of the day. And knock wood, so far I've managed to dodge this as well. We did have a couple very specific questions. Somebody asked about getting some Evusheld, but they got it at a time, I guess, where the dose was lower and now the dose is higher. That might be a Dr. Drews question more. Dr. Drews, talk about Evusheld. Who should use it, and is there anybody who should be thinking about getting it again or getting it at a different dosage?
Yes, so Evusheld is recommended for people who are immunocompromised and thought not to have a good response to the vaccine. And initially it was recommended in a lower dose, and anybody who received that lower dose, it is recommended that they receive, the other half, because it was a half dose, to make that full complement of the dose. Several people have received, previously, and after 90 days, then you're eligible to receive another dose of Evusheld so that you can stay protected.
Perfect. Well, that's very helpful. And then while I've got Dr. Drews, we did have a question about monkeypox, which is there anything specific that individuals should be doing right now to try to mitigate their potential risk for monkeypox?
So I think the biggest take-home message is that, we're not at high risk right now, but things that we could do to mitigate our risk is, anybody who has a fever or is sick, you want to make sure that they are tested. Particularly the rash is the hallmark. And so anybody that has, fever and rash, they should be tested, and you want to minimize your exposure to those type of people until they've been tested for monkeypox.
Okay, and of course it's so infrequent still. Let's hope
Exactly.
it kind of stays that way. So I think
Yes.
the short answer is kind of let's wait and see. But clearly, if it goes up, we may have to think about some of those things. And then finally, one last question is a very specific one, but will help out this individual. Had COVID 2 weeks ago, now going to Europe in a couple of weeks. Should they get another booster shot at this point? To Dr. Sossman's point, did they pretty much get their booster 2 weeks ago? What would you do in that case?
That I would probably talk to their individual physician so that they know all of their health risks. Most people I'm advising, if you've had a very recent case of natural infection, then an additional, everybody I advise to get that first booster. So 3 vaccines I think is good for everybody. But if you've already been boosted once and you just had recent infection, there may not be as much advantage to that second booster. And that really is probably something you want to talk to your own physician.
And there may be
a
timing issue there as well, perhaps, right?
Yes.
So, okay, well, great. Well, thank you very much. I'm going to wrap things up here. We've gone quite a bit late, but we knew we would with these couple of extra topics. And thank you to those of you who stuck around and who were interested in those additional topics. We're going to take a little summer break while hopefully all of you are taking a summer break. And we are scheduled for our next town hall on August 25th. Between now and then, we wish everybody a really, really wonderful, safe summer. We hope you have great travel plans, great time off, great time with loved ones and families, and we wish you the best of health. God bless.